So that's episcleritis for you. So you can see that there are two types of episcleritis. First of all, we need to know that it is a disease which is, it can be recurrent, it is idiopathic in the majority of patients, it is benign, and it can be bilateral. So episcleritis is classically known to affect young to middle-aged, and it is more common in women and can be asymptomatic to mild symptoms. So these patients don't really have raging pain, they don't have, they don't come to you with excruciating symptoms, they just come to us with mild symptoms and probably a complaint of redness in the eye. So the first thing we need to know is distinguish whether it is simple or nodular, because the two types of episcleritis have been established as simple and nodular. So what is this? The picture here is showing you a simple type of episcleritis where classically it can be, again simple can be either sectorial or diffuse. So what are these words mean? Sectoral, as the name indicates, is occupying one sector. So congestion is seen in one sector, as against diffuse where the entire conjunctiva is affected. So this kind of episcleritis called simple is a little more common, and nodular type is what you're seeing in this picture. You can see that nodule. This nodule is classical of episcleritis. Particularly, it has been found that it can be associated with herpes zoster ophthalmicus. So you have to go back and ask for a history of herpes zoster ophthalmicus. And in patients who use contact lens, or patients who have acne rosacea, or patients who have history of herpes zoster ophthalmicus, all these you can pay a little more. Of course, in collagen vascular diseases as well, such as rheumatoid arthritis, you need to ask. But these are conditions that we also need to keep in mind when you see a patient with episcleritis as possible risk factors for the development of this condition. Now, whenever you see a nodule like this, we always have to run through a differential diagnosis because nodules at the limbus is a very important topic by itself, and nodular episcleritis is one of the causes. Apart from that, you need to think of a cystic pterygium, a pincicula, a flectin. These are all, they don't look exactly like this, but they can look very similar. Then you can have limbal papillae in vernal conjunctivitis. You can have following parasitic cysts. So these are all differential diagnosis of nodules at the limbus, and definitely one needs to remember that nodular episcleritis is one of the most important differential diagnoses. So what do? If a patient comes to us with congestion, phenylephrine test is very useful. This is an alpha agonist. So what we do is we can use 2.5 initially. To distinguish between conjunctivitis and episcleritis, 2.5% phenylephrine test was recommended, but now we use a 10% phenylephrine to distinguish, to see if it's an episcleritis or a scleritis. If it's an episcleritis, maximum congestion will be abolished after phenylephrine, and that's what you're seeing in this picture. So this test will help to distinguish between episcleritis and scleritis, whether it's superficial congestion or a deep congestion. So how do you treat patients with episcleritis? First, we always start them on non-steroidal anti-inflammatory drops such as Fleur or Floribuphrin, or sometimes some people also give a course of systemic non-steroidal anti-inflammatory drugs, but topical will sufficient most of the times. Then you can also, sometimes the patient needs to be started on steroid topical medication again, because these patients have a little more significant congestion and inflammation, but you can give low potency or weak steroid. What we call low potency or weak steroids can be given for these patients, and most of the times they resolve. However, we need to bear in mind that it's a recurrent disease.